Bismillah ar-Rahman ar-Rahim. Our lecture today will be about the rickets. The objective of this lecture is to know what is the definition of ricket in general, what are the causes and types of rickets, because there are different types of rickets, clinical presentation of patient with rickets, what are the radiological and laboratory findings, which is the most important in diagnosis of ricket, what is the treatment and how is the prognosis. In general, the bone consists of a protein called osteoid. So this is a protein called osteoid, and a mineral phase, principally composed of calcium and phosphate, mostly in the form of hydroxyapatite. There are two definitions. One is the osteomalacia. Osteomalacia is present when there is inadequate mineralization of the bone osteoid. It occurs in children or adults, so it is inadequate mineralization of the bone osteoid. While ricket, it is a disease of growing bone. Occurs in children only, not in adults, before the fusion of the epiphyses, and it is due to the unmineralized matrix at the growth plate. So the ricket is at the growth plate when the child is growing, while the osteomalacia occurs in the bone osteoid, whether it is in children or in adults. Regarding the etiology, there are many causes of rickets, including vitamin D disorders, calcium deficiency, phosphorus deficiency, and distal renal tubular acidosis. We come across some of these causes. About vitamin D disorders, the most common is the nutritional vitamin D deficiency. There is another entity which is called congenital vitamin D deficiency. There are forms of secondary vitamin D deficiency in cases of malabsorption, celiac disease, Crohn's disease, and other chronic inflammatory disease, decreased liver 25-hydroxylase activation of the vitamin D. So in liver disease, there is secondary vitamin D deficiency. There is inherited forms of vitamin D deficiency, which are of two types: vitamin D dependent rickets type 1 and vitamin D dependent rickets type 2. And other causes is chronic renal failure, causes for the vitamin D disorders. Regarding calcium deficiency, either it comes from low intake, as in the diet, premature infants, thus to say rickets of prematurity. So the replacement of vitamin D is earlier in patient with a premature baby. And also when there is malabsorption. Malabsorption either because of primary disease or dietary inhibitors of calcium absorption. We may use some of the treatment which cause calcium, decreased calcium absorption. There is what is called phosphorus deficiency, in which either it is inadequate intake, also in a premature infant, and aluminium containing antacid. Sometimes we use antacid for gastric disease, which contain aluminium, which bind phosphorus and cause phosphorus deficiency. There is another cause for the phosphorus deficiency is the renal loss, in which there is X-linked hypophosphatemic rickets, autosomal dominant hypophosphatemic rickets, hereditary hypophosphatemic ricket with hypercalciuria, tumor-induced rickets, McConnell-Bright syndromes, neurofibromatosis, and Fanconi syndromes. All these, there are deficiency of the phosphorus by the renal loss. And there is entity what is called as distal renal tubular acidosis, and this you will come across in a case of renal disease when you discuss renal disorders. Clinical features of ricket. These are the general clinical features, regardless the etiology. So it may come, you may see in a nutritional ricket, or you may see in a hypophosphatemic ricket, or you may see it in the other forms of rickets. In general, there is failure to thrive, sweating, protruding abdomen, muscle weakness, and fracture, green stick fractures. In head, we find craniotabes, Craniotabes, this is a sign we saw it in the head. When you press the occipital bone, there will be inward invagination of the occipital bone and later on return back to normal because of the soft bone. There is a frontal bossing. The head will be like the box. Delayed fontanelle closure, and one of the cause of wide anterior fontanelle or the delayed closure of the fontanelle is the rickets. And also there is delayed dentation, and this is the most common cause for the consultation about the rickets. And there may be dental caries. Regarding the chest, there is what is called the ricketic rosary due to the enlargement of the costochondral junction. There is Harrison groove due to the pull of the diaphragm on the thoracic cage, and patient may have respiratory infection and atelectasis. In the back, there may be scoliosis, kyphosis, and lordosis. In the extremities, enlargement of the wrist and ankles, or valgus or varus deformity, and sometimes anterior bowing of the tibia and the femur, and patient may complain from leg pain. There is hypocalcemic symptoms. The patient may present with tetany, seizures, or stridor due to the laryngeal spasm. These are some of the pictures which show the clinical presentation. This is the widening of the wrist. Widening of the wrist. Because of the undermineralization of the growth plate, there is widening of the wrist. And this is what is called Harrison sulcus. Because of the pull of the diaphragm on the thoracic cage, there will be sulcus, مثل الأخدود, and the lower part of the thoracic cage, above the costal margin, due to the pull of the diaphragm on the soft rib bone. Ricketic rosary. These are the ricketic rosary. The site of the costochondral junction, it looks like a bead when you come across by your hand. This is another picture for the Harrison sulcus because of the pull of the diaphragm, and the patient will have abdominal distension because of the weak muscle of the abdomen. And this is what is called as the valgus deformity of the legs. These are some of the clinical features of ricket. The chief complaint that the child comes for the medical attention is quite variable. Many children may present because of the skeletal deformity and which is late presentation of rickets, whereas others may have difficulty walking due to the combination of deformity and muscle weakness. So the patient presents because of delayed walking. They said that he is 1 year old and still he is not walking. Other may come because of the bow legs, because of the early trial or attempt to make the baby to walk with soft bone may cause deformity of the leg. Other common presenting complaints include failure to thrive. Other presentation may cause because of delayed dentation. This is the chief complaint which the patient comes with. Regarding the radiology, this is very, very important as essential in the diagnosis of the ricket. Ricketic changes are almost easily visualized on the posterior anterior radiograph of the wrist, so we do X-ray of the wrist. Although characteristic ricketic changes can be seen at other growth plates. We may see it in the knee, we may see it in the hip, we may see it in other place, but we use X-ray of the wrist because it is more evident and it is away from the body to decrease the effect of the X-ray on the other part of the body. There are specific signs. The edge of the metaphysis loses its sharp border, which is described as fraying. Fraying يعني مثل البلاستيك المفطر. In addition, the edge of the metaphysis change from a convex or flat surface to a more concave surface. This is termed as cupping. We will see it in the X-ray. Cupping look like a cup, become concave, and is almost easily seen at the distal end of the radius ulna and the fibula. there is widening of the distal end of the metaphysis, and this is correspond to the clinical observation of thickened wrist and ankles. Other radiological features include coarse trabeculation of the diaphysis and generalized rarefaction. So these are the signs which is seen in X-ray of child with a ricket. This is what we said. There is rarefaction of the epiphysis, of the radius and the ulna, and there is wide distance between the metacarpal and the ulna and radius. This is because of defective ossification, so it will not seen in the X-ray. And there is cupping, look like a cup, okay? And there is rarefaction of the metaphysis. So these are the signs of ricket, and this is correspond to the widening which we will see in the wrist and sometimes in the ankle joint. Most cases of rickets are diagnosed based on the presence of classical radiographic abnormalities. The diagnosis is supported by physical examination findings and history and laboratory test result. So it depends on the history, physical examination with the classical X-ray changes and some of the laboratory tests. This is to diagnose the type of rickets. Regarding the clinical evaluation, what important part in the history which may help? Because the majority of children with rickets have a nutritional deficiency, the initial evaluation should focus on a dietary history, emphasizing intake of vitamin D and calcium. Sometimes the families they are delayed in presenting a solid food for the baby and demand only on breastfed. As a breastfed, it is not a good source for the vitamin D, and it will not continue to supply the patient with vitamin D for the whole year of life. It is sufficient for the first 2 to 4 months, so the patient may have deficiency of vitamin D. So we concentrate on dietary history. In addition, cutaneous synthesis mediated by sunlight exposure is an important source of vitamin D, and it is important to ask about time spent outside and the clothing. Winter sunlight is ineffective at stimulating cutaneous synthesis of the vitamin D. So, children with increased skin pigmentation, that's to say negro, are at increased risk of vitamin D deficiency because of decreased cutaneous synthesis. Keeping in mind that sunlight across the glass, يعني عبر الشبابيك, it is not beneficial for the synthesis of vitamin D. And so, in our culture, because of the hot summer and cold winter, we are avoiding exposure of our babies to sun. In the winter because of the cold weather, and in the summer because of the hot weather, so the baby may have vitamin D deficiency because of this problem. The presence of maternal risk factor for nutritional vitamin D deficiency, including diet and sun exposure, is an important consideration when a neonate or young infant has rickettsial findings, especially if the infant is breastfed, what is called congenital ricket. So, this congenital ricket, it appears earlier during the neonatal and young infancy, while other form of ricket we see it in the later or second half of the year. While in congenital ricket, we see it in the neonatal or young infant. This is because of maternal risk factor, because she is deficient in vitamin D during pregnancy, and her breastfed is not sufficient because she is deficient in the vitamin D. History regarding the medication use, because certain medications such as the anticonvulsant phenobarbital and phenytoin may increase degradation of vitamin D. Also, aluminum-containing antacid interfere with the absorption of the phosphate and may lead to the rickets. So, we must supply the patient with vitamin D when he was on the anticonvulsant phenobarbital and phenytoin, especially in the infancy. Malabsorption of vitamin D is suggested by history of liver or intestinal disease. There may be signs or symptoms suggestive of deficiency of other fat-soluble vitamins, vitamin A, vitamin E, vitamin K, not only vitamin D. and so we must ask about the history of malabsorption syndrome. A history of renal disease when the patient have proteinuria, hematuria, UTI is an additional significant consideration given the importance of chronic renal failure as a cause of rickets. The family history is important as there is large number of genetic causes of rickets, although most are rare. So these parts we must cover it in the history to find the cause of rickets because the treatment of each type is different from the other type. Regarding the physical examination, we focus on detecting the manifestation of rickets as we said. In addition, it is important to see the gait, auscultate the lung, and to detect atelectasis or pneumonia and blow the patient growth. Because in nutritional ricket, it is a disease of growing child, while if we find a signs of ricket in a patient with failure to thrive or short stature, we must look for other causes of ricket other than nutritional rickets. Presence of alopecia suggests vitamin-dependent ricket type 2, and we have some families with this type of ricket. They are not responding to the usual treatment of vitamin D, and they may need extraordinary dose of vitamin D. Regarding the initial laboratory test, we did any patient suspected of ricket, we sent for serum calcium, phosphorus, alkaline phosphatase. Always, in any case of ricket, the alkaline phosphatase should be elevated. Presence of normal or low alkaline phosphatase make query about the diagnosis of ricket. We send also for parathyroid hormone, looking for secondary hyperparathyroidism because of vitamin D deficiency. Estimation of the level of the vitamin D, whether 25 or 125 dihydroxyvitamin D. We send for a creatinine and electrolyte, and some other investigation according to the suspected etiology of ricket. For example, general urine if we suspect a patient with Fanconi syndrome for detecting glucosuria and amino acid urea. So the initial investigation include calcium, phosphorus, alkaline phosphatase, parathyroid hormone, vitamin D level, urea and creatine and electrolyte, and other investigation according to the suspected etiology of ricket. We will come across the most common cause of ricket, which is called nutritional vitamin D deficiency, and we will concentrate on what is important point to take it in consideration when we are dealing with vitamin D deficiency due to the nutrition. It most commonly occurs in infancy due to the combination of poor intake and inadequate cutaneous synthesis. We know that transplacental transport of vitamin D typically provides enough vitamin D for the first 2 months of life, unless there is severe maternal deficiency, as we said, and the patient may present with congenital ricket. A breastfed infant, because of the low vitamin D content of breast milk, rely on cutaneous synthesis or vitamin supplement. This is not against the breastfed, but any patient with any child or infant on a breastfed should be supplemented by vitamin D. Previously, it is called at the 4th month of life. Now it is indicated to be earlier. Cutaneous synthesis, as we said, can be limited due to the ineffectiveness of the winter sun in stimulating vitamin D deficiency, avoidance of the sunlight due to the cultural practice, as we said, مثلا نقمط على الطفل, or decrease cutaneous synthesis because of increased skin pigmentation. Infants who receive formula receive adequate vitamin D even without cutaneous synthesis. This is not a promotion for the formula, but in formula milk they add vitamin D with the milk. Clinical manifestation. I will not repeat the clinical manifestation of ricket because it is typical of ricket mentioned earlier, and with a significant minority presenting with symptoms of hypocalcemia. So rarely we find patients with nutritional ricket present to us with convulsion or with stridor or with carbopedyl spasm. But we find typical features as mentioned above, previously, like craniotabes, bossing of the head, rachitic rosary, widening of the wrist, bowing of the leg, delayed dentation, any other symptoms and signs we mentioned earlier. Regarding the laboratory findings in a patient with a nutritional ricket, the most important is hypocalcemia variable finding due to the action of the relevant elevated parathyroid hormone to increase the serum calcium concentration. So the patient may have normal or low calcium. This is depend what is the effect of elevated parathyroid hormone, whether it is compensated or not. Hypophosphatemia is always present due to the parathyroid hormone-induced renal loss of phosphate, combined with a decrease in the intestinal absorption. So, hypophosphatemia is present, but calcium is variable. Also, vitamin D, active vitamin D is variable. It may be low, normal, or high. It is a matter of equilibrium between the demand and the what is present really. Because if we have a child who grows very rapid, even a level or normal level of vitamin D will be not sufficient for his growth. And sometimes we have a low vitamin D, but still we don't have signs of ricket. This is because the child, especially in a child who is failure to thrive. And we will have the signs of ricket when the patient start to grow. So it is a matter of equilibrium between the level of the vitamin D and the rapidly or the amount of the growth of the child. And the vitamin D level is only low when there is severe vitamin D deficiency. Alkaline phosphatase is usually high, and parathyroid hormone is high. So if we compare the laboratory finding of ricket with a patient with hypoparathyroidism, as we mentioned earlier, we find the parathyroid hormone is high, alkaline phosphatase is high, while in the case of hypoparathyroidism it is normal or low. In patient with hypoparathyroidism, the phosphate is high, while in ricket the phosphate is low. The calcium is low in patients with hypoparathyroidism, but it is variable in the patient with rickets, and special nutritional ricket, as we mentioned here. So this is to differentiate between the laboratory differentiation between the when patient present with hypocalcemia due to the hypoparathyroidism or present with hypocalcemia and signs of ricket due to the nutritional rickets. Regarding the diagnosis, it is based on the combination of history of poor vitamin D intake and risk factor for decreased cutaneous synthesis. This is in the case of nutritional ricket, as we said. In addition to radiographical changes, cupping, fraying, and decreased mineralization or rarefaction of the metaphysis, and the typical laboratory findings, as we said, low or normal calcium, hypophosphatemia, and elevated serum alkaline phosphatase, and decreased vitamin D, or sometimes it is normal, as we said previously. Treatment. Children with nutritional vitamin D deficiency should receive vitamin D and adequate nutritional intake of calcium and phosphorus. There are two strategies for administration of vitamin D. The first strategy, we give 300,000 to 600,000 international units of vitamin D administered orally or intramuscularly as 2 to 4 divided dosage over 1 day. Because the doses are observed, this is ideal in situation where adherence to the therapy is questionable. Always or most time we have poor compliance with giving vitamin D on daily basis, especially in our community. So sometimes when we suspect that the compliance will be poor, so we give a single dose of high dose of vitamin D. The alternative pathway is to give daily high dose vitamin D with doses ranging from 2,000 to 5,000 international units per day over 4 to 6 weeks. This is better, and this is avoid the side effect of hypervitaminosis, but sometimes we enforce to use the first therapy, especially when there is no compliance of the family. In either strategy should be followed by daily vitamin D intake of 400 international units, which is the daily allowance of vitamin D needed by the normal babies, typically given as multivitamins. after we finish this course of treatment. In addition, it is important to ensure that the children receive adequate dietary calcium and phosphorus. This is usually provided by milk formula and other dairy products. While in the case of hypoparathyroidism, we limit the dairy products. Children who have symptomatic hypocalcemia may need intravenous calcium, followed by oral calcium supplements, which typically can be tapered over 2 to 6 weeks in children who receive adequate dietary calcium. So sometimes we need IV calcium to treat stridor. Prognosis. Most children have excellent response to treatment, with radiological healing occurring within a few months. Many of the bone malformation improve dramatically, but children with severe disease may have permanent deformity. These are the signs of healing of rickets: the appearance of the white line at the growth plate. Appearance of the white line, this indicates healing of rickets. So, when we give the patient vitamin D, we return him back after 1 month to 6 weeks to do X-ray of the wrist. We will see sign of the healing. That is, there is no concave, there is no rarefaction, and the appearance of the white line. So these are the signs of healed ricket. Regarding the prevention, most cases of nutritional ricket can be prevented by universal administration of daily multivitamin containing 400 international units of vitamin D to children who are breastfed. For other children, the diet should be reviewed to ensure that there is a source of vitamin D. I will come across this entity because we may see it in the pediatric practice. This is what is called congenital vitamin D deficiency. It occurs when there is severe maternal vitamin D deficiency during pregnancy. Maternal risk factors include poor dietary intake of vitamin D, lack of adequate sun exposure, and closely spaced pregnancy. All these are common in our community. These newborn may have symptomatic hypocalcemia, present with intrauterine growth retardation and decreased bone ossification, along with classical rachitic changes, and predispose the infant to neonatal hypocalcemic tetany. So the neonate present with classical rachitic changes and may present with hypocalcemic tetany. Treatment of congenital ricket include vitamin D supplementation, as we said, and adequate intake of calcium and phosphorus. Keep in mind, we must treat also the mother in order to avoid for her health care and to have a good supplement of vitamin D via the breastfed, when she breastfed her baby, and to avoid the recurrence of congenital vitamin D in the second pregnancy. Thank you very much. Thank you.